Today, I'm going to talk about implants in general. I'm sorry for the technical difficulties that are occurring right now. Unfortunately, sometimes that happens with live stuff. On Monday night, I'm going to discuss not just implants like today, but we're also going to discuss full mouth restorations. And so Monday night at 7 o'clock, if you're interested, we'll set up a sign up for that. And that's for full mouth rehabilitation. So say that you're not just missing one or two teeth, but you're missing all your teeth, and you want to know more about that process to replace teeth. You've probably heard of terms for it used on TV, teeth in a day, and all on X, all on 4, whatever. And that's the type of situation that we'll be talking about then. Today, though, I'm going to talk about just dental implants in general. And what steps lead to lifelong success. And you really want, when you have an implant, you don't want it to look any different than the rest of your teeth. And part of the issue with that I see in so many cases, we get referrals for not just the cases that we place implants on, but we get a lot of referrals for when patients have had implants placed somewhere else and they're not happy with the way that turned out, or they're infected, or they don't look good, or something. And part of the issue in making an implant last long term and have something that you're really excited about is the space where that tooth was needs to look the way it did when the tooth was there, minus the tooth, of course, but the shape of your gum, the thickness of your gum, all that stuff needs to be prepared before you place the implant. And if that's not done, then a lot of times you end up with a divot or a deficit or a long tooth. You don't want that appearance. Sometimes we can correct things like that, and sometimes we can't. It's always better to have that kind of stuff done on the front end. So whether you're coming to see me or someone else like me that does implants, one of the things that you want to ask for is, what do you do to develop the site where the tooth was so that it looks like a natural tooth? And then other questions that you should think about when you're having, or if you're considering an implant in the future, is is there a way that you can determine the outcome before you do it? Like, I always like to start with the outcome in mind before we ever finish. And in fact, on most cases, what we'll do, not most cases, just about every case, we'll take a 3D x-ray, and then we'll do a digital image, a digital scan of that patient's teeth and their arch. And then on a computer, I'll complete their entire case on a computer before we ever do it in them. The advantage of doing something like that is if there's any deficits in the gum, if there's going to be recession, if there's not enough bone, if the tissue's not thick enough, if the bone's not hard enough, all those things can be determined in advance. And so whoever you see for your implants, those are questions that you might want to keep in mind. How do you know the outcome before you begin? Are you just have you just been to a weekend course and you're to make a hole and screw an implant? And if that's the case, you're at greater risk of ending up with something that you're not happy with. The other thing about dental implants is the bite is really important. You know, with your natural teeth are surrounded by a ligament. And this ligament attaches your tooth to the bone, but it provides some cushioning in your teeth. So when you crunch or bite on things, your natural teeth can actually move just a little bit, 1/4 of a millimeter. I know it doesn't sound like much, but it's still some movement. A dental implant, on the other hand, once it's in the bone, it's what we call ankylosed. It can't move at all. There's no buffer whatsoever. So the bite on a tooth that's being held up by a dental implant has to be perfect. And so whoever does your implants, whether it's us or someone else, the bite needs to be configured and properly done when the crown goes on top of the implant. And then finally, implants need support long term. So they're not more durable than your natural teeth. In fact, it's just the opposite. Your immune system will fight for your natural teeth, and your immune system will not fight for your implant. And so if you can preserve a natural tooth in any way possible, that's a great way to go. But of course, there's instances where you can't. Say that you've had a root canal and the root canal failed, or you've had a huge abscess on a tooth and a root canal is not really a good option anymore because it leaves so much infection in the bone, then a dental implant's a great way to go. But even after you've had the implant done, you need to have that area checked periodically to make sure that the gums and the bone are healthy around the implant. So it can last a lifetime, but it's your immune system isn't going to fight for it like it would a natural tooth. In fact, just the opposite. If your implant gets infected, your immune system will do everything it can to get rid of that implant. And so regular care is important. This is my staff. I've shown you this in other webinars that we've done. We've been keeping records of our implants that I've been placing since 1991. Seems like a long time, doesn't it? But I can tell you that our success rate since 1991 is 97%. And that's a pretty good success rate, because when you look in the literature and you ask how successful are dental implants, almost every dental implant manufacturer will tell you that their implants are 97, 98% successful. But what they don't tell you is those statistics are taken in 2 years of study, not 30 some odd years of study. And the thing is over time, the failure rate of some implants can be much less. There was the American Dental Association published a paper just a little over a year ago that showed that practice-based research program where they were following general dentists, not specialists, but general dentists throughout the country, and their success rate was only 80%. And so it makes a difference to go through those steps I mentioned before, and then to have supportive care over the long haul, just because it makes your success rate so much better. Things to think about. So when you lose a tooth, whether it's taken out via extraction or trauma, when that tooth leaves the socket, imagine this, the bone that held that tooth isn't being used anymore. So the body, well, what's the body do? It tends to resorb. And so on average, patients lose about 60% of the volume of the bone that held the tooth in the mouth in a 3-month time frame. So it's critical to graft those if you're having an extraction, whether it's due to infection or gum disease or whatever. That area needs to be grafted in such a way to preserve the anatomy of your bone. The anatomy of your bone is actually more important than the tooth that's being held by the bone, because we can replace a tooth pretty easily with an implant, but regrowing your natural architecture, your arch, the bone that held the teeth in the mouth, is more difficult. And so those things need to be taken care of in advance. Gum disease and cavities lead to bone loss as well too. I see lots of patients that have cavities on the roots of their teeth, and that'll cause their gums to recede, and it'll cause the bone in that area to go away as well. When your tooth is being taken out, when I was in dental school, we learned to really rock a tooth back and forth, and that's called a luxation. But that level of luxation can actually cause breaks in the bone that surrounds the tooth. And so really the best way to extract a tooth without so much trauma is rotational extraction. And there's instrumentation today where you can elevate a tooth just a little bit and then rotate it out of the socket. I know that sounds horrible, especially while you're probably at lunch. But there's atraumatic ways to extract teeth. And if they're possible, they should be done. And then, of course, after the tooth is taken out, the socket needs to be grafted to preserve the natural shape of the bone. So I'm just going to show you some outcomes. So in this top picture, you'll see a lady who had lost her front tooth. We call it tooth number 9. It's her central incisor. And she's wearing a removable or temporary bridge in place right now. And notice she has kind of a gummy smile. So she wanted to address several things. She wanted to address the gummy smile and replace the missing tooth. So on the next picture to the right of this one, you can see that I did something called crown lengthening. I reshaped her gums so that her teeth had a more pleasant appearance. I used a procedure called crown lengthening to make the gums frame her teeth like a picture has a frame. The teeth should be framed by the gingiva. And so I reshaped her gingiva, And then you can see on the bottom photo, there's an x-ray. We placed an implant in the bone, and then we put a temporary tooth on it to mold the shape of her gum as it heals. And you can see in the next picture over both the outcome of her crown lengthening and her temporary crown that she has in place. So that's what I would call site preparation. That's what you want to do to make a case look good over the long haul. Other things to be concerned about are the shape of the crowns, the spaces in between the crowns. The way that the two teeth come together, where they meet in the middle, is called the interproximal contact. And believe it or not, that contact needs to be an oval. It needs to be shaped in a certain way. And if it is, it actually promotes gum tissue healing between the teeth. And if it's not, then you end up with a little space between the teeth and you get a little black triangle. Research has shown the key to success in that is the interproximal contact, that spot where the two teeth meet, needs to be at least 3 millimeters, or needs to be no more than 3 millimeters above the bone. And that's really important. So when you're dealing with your dentist or whoever's doing the restoration, to make sure that those spaces aren't there, those things need to be taken into consideration. Before treatment begins, so one of the things you want to do is you want to make sure your dentist knows all about the medical history that you have. Medications make a big difference. Did you know almost all blood pressure medications cause dry mouth? And so whether you're taking losartan or a beta blocker like metoprolol or a diuretic, all those things cause a dry mouth. And a dry mouth makes it where you're at much higher risk of getting in cavities around the necks of your teeth, around the margins, where if you have crowns, recurring cavities around the margins of those crowns is a big deal. And also with dental implants, one of the things you want to take into consideration is if you're on certain medications that cause dry mouth, what can we do to manage dry mouth? The dental implants won't get an infection, or they won't get a cavity, but you still want to make sure that that dry mouth doesn't lead to gum disease as well. So there's things that you have to do to manage around that. Other medications, like a lot of patients take Boniva or Fosamax or some type of, they're called bisphosphonates, and they're drugs that you use for osteoporosis. If you're having dental implants or you've had gum disease, you want to avoid the bisphosphonate class of drugs for osteoporosis because it makes it where your bone could actually die in your mouth. There's a process called osteonecrosis. And the way a bisphosphonate drug works is it turns off the cells in your bone and it makes the blood supply to your bone all shrink up. And so if you've got osteoporosis, the medications that you take, and they're all alternatives to bisphosphonates. There's other drugs you can take that don't lead to osteonecrosis like the bisphosphonates do. So it's just something you need to share with your dentist, and they'll need to address that if that's a problem. Another thing to consider is, do you wear a CPAP or a night guard? And if you do, that needs to be incorporated into your plan for your implants too. For example, certain types of night guards actually cause your lower jaw to retrude, to push backwards. And those night guards, if you're using a CPAP, they actually work against your CPAP because it's making your jaw move backwards, it's closing off the back of your throat. And so if you're using a CPAP, it won't be as effective. So the type of night guard you'd want would be one that would make your lower jaw move forward just a little bit. It opens up the back of your throat, making your CPAP work so much better. And there's other types of appliances that many patients with mild to moderate sleep apnea can replace the CPAP altogether. So, and other things to consider are in your surgical plan, how are you going to temporize the site while your implants are healing? Yes, in some cases, like if we're replacing all the teeth, we screw in teeth the same day. But sometimes if you're just having a single tooth replaced, sometimes it can have a temporary on it, sometimes maybe not, because it's under more forces. And if the implants aren't all splinted together, they're not as safe with a temporary on it. And so those are things that you have to consider in advance. And types of temporaries that you might have, our favorite that we like to use is this first one called Biotems. Biotemps have a really smooth, perfect contour. They look good, and they're actually screwed on top of the implants. We use biotemps a lot when we're placing implants. Another type of temporary is called a temporary Maryland bridge. So it doesn't attach to the implant, but it's bonded to the adjacent teeth. And that's also a very nice type of temporary to keep from having trauma on the implant while it's healing. We have another type of temporary called transition smiles. And these type of temporaries snap in over your existing teeth. And so for a case where we're replacing maybe all the front teeth, but we don't want any pressure on those front teeth while they're healing, we would use something like a transition smile. And then my least favorite, but sometimes necessary, is this temporary called a flipper. And it's a removable partial denture. It comes in and comes out of the mouth. The advantages of a flipper are they're quick and they're easy to make. The disadvantages of a flipper is they put pressure on your gums. So you can have a little recession under a flipper when you wear one. So this is a demonstration of a snap-on smile. So in this particular patient, I replaced the lower anterior teeth, but I didn't want any pressure on those teeth because I was building up the bone around those implants and the gums at the same time I was placing the implants. So we provided a snap-on smile. That's called a transitional appliance that you snap in over your teeth. It looks good, it functions well, but it doesn't put any pressure on the implants. Other things that that we can do to enhance the outcome is we use lasers in this office. And so we'll use a laser to shape the gum or shape the sulcus around a tooth to make it look symmetrical to the adjacent teeth. Sometimes when a crown's being placed on top of an implant, the gums will fit so tight around that crown that you can't get the crown to go all the way into place. And so we'll use a laser to reshape the gum in a spot like that. So this is a case like that. This was a patient where the temporary crown was pushing into the gum so hard that it was causing the gum to turn white. And so we used a laser to reshape it, and you can see the outcome looked much better. How to prevent infections around dental implants. That's a really important thing. Typically after an implant's just placed, you'll be placed on antibiotics. But then after the gum and the bone heal into an implant, how the implant was placed is really important. There needs to be a certain amount of bone around that implant. On this, it says 2 millimeters of the buccal plate and 2 millimeters from other teeth or 3 millimeters from other implants. Those are all things that should be planned in advance of placing the implant. That's what we do when we take a 3D x-ray. And we do your case online or on computer. We'll actually plan for the thicknesses of bone, the thicknesses of soft tissue, and we'll modify any of that we need to before we place an implant. A huge factor in implant infections is cement. So if you have to have a crown that's cemented on top of an implant, sometimes the cement squeezes down underneath the gum and onto the implant or onto the top of the implant. And that's almost guaranteed to cause an infection within 2 years. And so if you have to have a cemented restoration, that has to be checked and cleaned really thoroughly. We advocate using screw-retained crowns whenever possible. And today, technically, you could use a screw-retained crown for almost any implant crown. And then another thing to consider is professional home or professional care, not just good home care, but professional care in the dental office. You know, especially during the first year. You know, after you've had an implant placed and the crown restored on top of the implant, the tissue around that implant matures for 6 months. And for that 6 months of time, you're more susceptible to an infection than you would be normally. And so you want to have professional routine cleanings, especially during the first year after an implant, because that prevents so many problems. And then after you've had an implant placed, a key thing that we really like is the Waterpik makes a device called the Waterpik Sonic Fusion. It's an ultrasonic toothbrush, and the Waterpik comes out of the bristles. You know, the problem with Waterpiks in the past, where when you hold a Waterpik and you're using just the Waterpik on your teeth, you have a tendency to angle it up at the teeth or the gums. and the water pressure, you tend to use it too high. And what can happen is it can cause your gums to recede. And so I've seen lots of patients who have water picks around their teeth and implants, and if they're used improperly, they cause the gums to recede. And another problem with traditional water picks is sometimes it can actually cause food to impact deep in the gum. So if you're angling up at the gum, and instead of blowing the food debris out the inside, it can actually push it deep into the gum. And so sometimes the water pick, just a free-handed water pick, can actually be a problem. Whereas with this sonic fusion, since the bristles are up against the teeth at a 90-degree angle, the water's coming at the teeth always at the proper angle. And they did develop a home run with this device. Water pick sonic fusion, I've never seen anything that cleans better than this type of device. So this is just showing you what it looks like to plan a case in advance. So on the top part of your picture, you can see a 3D X-ray. So I can see the teeth from the front, from the sides, from on top, and I can actually rotate those images and move through them. And on one of the windows, I can actually rotate it in a circle and see the bone and the teeth in complete volume. And then we make something, the bottom one picture that's in yellow, that's a digital impression. So we used a wand that has a camera in it, and we took an impression of that patient's teeth with a wand. And then with the software, I can actually combine the image that we took with the camera with the X-ray. And now when I'm planning a case, I've got everything I need. I can actually place, in this photograph, you can see I've placed the implant inside the bone. And now I've fabricated a tooth that's in red. And I'm showing in that yellow sphere that's coming out of the middle of that red tooth, that's the emergence profile of that implant. So in that particular case, you can see that I've placed the implant so that it emerges right in the middle of that crown. And so that tooth can be screwed into place, and then that hole where it was screwed in can be filled up with composite, so you'll never see it, but it allows us to have access to that crown anytime we need it. So this is just more of the planning process. So I've made a surgical guide. That's what the bottom part of that picture is, that will fit in someone's mouth. We have 3D printers in the office. And so once I've planned where an implant's going to go and how it's going to look, I'll print this 3D device that I can place in the patient's mouth and then duplicate the placement that I had in the computer immediately back into the patient. So this is just a patient who had bone loss around their teeth, and they had a bridge. The bridge became mobile. They had options for root canals and other things, but sometimes the teeth are so far damaged that those aren't a good option anymore. So we have to plan on what's going to work. What's the best value for your money in the course of 5 years, 10 years, 15 years. What happens if you do a root canal on a tooth that has a large abscess at the tip of the root? And so the root canal takes care of the infection inside the tooth, but it didn't clear the infection outside of the tooth. Well, if they've got large abscesses, sometimes those large abscesses just are there for life or for years. I've taken out teeth on patients who had root canals placed 10 years ago, and they still had an active infection at the tip of that root. So your issue is with something like that, that it raises your risk of, it raises the inflammation in your body, which raises your risk of heart attack and stroke over time. So other situations are, maybe we could do the root canal and you could have what's called a post and core, and I could do bone regeneration to repair all the bone around a natural tooth. But in the process of doing that, there's more artificial things on that tooth now than there are natural. How long will those artificial things hold up over the course of your life versus doing an implant? So those are things that need to be measured. In general, I will tell you that I lean towards preserving natural teeth whenever possible. But in the process of preserving a natural tooth, if it would cause destruction or damage to the adjacent teeth, then we have to reevaluate what's the best option. So in this particular patient, we treated that patient's gum disease. So they had gum disease, and I used a laser to clean up the infection and regrow the bone around their teeth. But the bridge in front we ended up having to replace. And this is just talking about we completed the periodontal treatment, and that this patient had bone loss around the 2 teeth that we were going to take out. So I have to repair the bone as well as place the implants. So during the planning, I determined the size of the implants and their spacing and location. And so here you can see on this, you see the patient's bridge in the front. And now you can see in 3D how I've removed those teeth, and I'm planning on where the implants are going to be placed. I can also at that time determine how much bone do I need to do soft tissue grafting, hard tissue grafting? Do I need to do it in advance of implant placement, or can I do it at the same time? So here, and also I have issues where the natural teeth, were they in a good location in the arch, or had they drifted? And do I need to make allowances for that as well? And then, just as we talked in the beginning, proper implant placement so that the long term these can be maintained. So in this particular case, we're doing what's called a flapless surgery. I'm going to use instruments that make like a cookie cutter hole in the patient's gum. And then I'll place a surgical guide in place and place the implants. And then I'll make these screw-retained temporary biotims that we talked about in the beginning. So that when the patient walks out, he's got crowns on top of his implants and everything splinted together. Then I took into consideration, did I need to graft, and how dense was the bone, and how close is it to the adjacent teeth? All those types of things were planned in advance. So this is just another case like the one I showed you the first time, showing you a patient had a bridge that had failed, and I took out the bridge, I took out the teeth that held the bridge, I placed 2 implants, and then I made temporaries. And so you can see it's a little bloody. I apologize for the appearance of blood on there, but that's immediately after surgery what it looked like. This is the same type of thing with a single tooth. Patient lost his very front tooth, and I placed an implant. And on the picture to the right, you see a tooth on a die. I actually made his tooth outside of the mouth, and then I unscrewed it off this die and screwed it into his teeth, or his implant. Notice that I made this tooth a little bit shorter than the adjacent tooth. This is a temporary tooth, and I didn't want the patient to put any bite pressure on it. So I took it out of, I made it where when he closes his teeth down, he couldn't hit that tooth. Same type of thing, another patient who's about to lose, and this is showing you maybe more or less than you want to see of an actual surgery. So if you're squeamish about blood, this might be the time to quit watching. But this is an actual surgery. So I rotated the tooth from this patient's socket, and then I placed an implant. And the middle picture is the implant with a temporary crown. I made a screw retained crown, and then the bottom picture is that temporary crown in place. And again, I made this crown a little bit shorter than I did the adjacent tooth, so the patient couldn't bite it. When the patient bit, they couldn't bite. Now the finished restoration would be normal length and look like the adjacent tooth as far as height and width and all that. But for the temporary that we did the same day as the surgery, I made it where there was no pressure on the implant. Sometimes I have to make the bone thicker or wider. And so in this particular case, on this young lady, her bone, when she'd lost that tooth, she'd lost the volume of bone that we talked about in the beginning. So I'm actually doing what's called a tunnel procedure to slide graft underneath her gum to make it thick and full again, so that you can see on the bottom picture, it makes her teeth and gums look normal. So thank you so much for watching. If you'd be interested in watching a presentation on full mouth restoration, we're going to talk, or I'm going to talk about something called Hybridge on Monday evening. And Hybridge is full mouth reconstruction. So if you're interested in that, you can send us a note at fortbendperio@gmail.com. We'll also send out an email to everyone that's attended this. And if you have questions, if you have things that you want me to discuss that I haven't discussed, put it in the chat box or send me an email. Either way, I'm glad to go over it. And so thank you all for attending and watching this. And if there's anything we can do to help you, if you've got more questions, please add them to the chat box. I'll see them now, I'll see them later, or email me, either way. And actually, before we leave, I'm just going to kind of look and see if there's any of these chat messages. Oh, someone said, please send me a recording. For everyone that's registered that attended this, we'll send out a replay link afterwards. Now, I apologize for the sound at the beginning. What a pain, huh? Anyway, thank you so much. I appreciate it.